I chose the topic of burnout for my grad round, and yes, I'm a rheumatologist who want to talk about physician burnout. I wanted to discuss this topic because I believe that it's something long time coming. We have to, you can see the latest news, there is so much focus on physical wellness and why burnout is becoming a big challenge. This is a challenge because it's affecting the way we take care of our patients. And most importantly, it's also affecting us, how we take care of our own self. So I wanted to do the burnout topic, and I will go with the physician burnout and try to explain that to improve our well-being, it's not going to require a lot of effort, a lot of money, but it needs to just change a little bit mentality and change the culture of medicine. So I have no disclosures. There's no conflict of interest in my talk. So I want to start by saying medicine is a combination of science and art. Science is knowledge. Science is knowing, something that we all go to med school to learn. And art is caring and communicating, something our patients need from us all the time. So if you have one component missing, then it would not be true patient care. So in the talk, we will first define what physician burnout is, then describe what are the contributors and what are the consequences of physician burnout. And at the end, we want to see what can we do to prevent burnout, what kind of interventions have been used in other institutes, and something that we also have to look into to implement to improve physician well-being. So what is burnout in physicians? Burnout is a syndrome of depersonalization, emotional exhaustion, and low personal accomplishment, leading to decreased effectiveness at work. It has been recognized as one of the increasing epidemic. Recently, it's been called as a public health crisis. And believe me, it affects all stages of physician training, starting right from the med school to the level till you keep practicing medicine. And it does affect all specialties, including rheumatologists too. National physician burnout rate is 54%. And more than 500,000 physician burnout is recorded or reported at any given time. This is a study showing that 45% of US physicians reported at least one symptom of burnout. And when they were compared to their working colleagues or US adults who are not involved in the healthcare field, they had more symptoms of burnout and they were dissatisfied with their work-life balance. What is depersonalization? It's a feeling that you stop thinking people as people. They become object. You become callous toward patients. You get callous toward people. They don't look living to you anymore. And emotional exhaustion. What is emotional exhaustion? That you feel so tired and you feel you are being at the end of the rope. You're fatigued and tired all the time. What are the triggers which are more characteristic of physicians? That's why it hits us hard. These triggers include that we are all conscientious. We want our patients to get better. So there are days we go home and we cannot relax because we know our patients were sick. Sometimes we have excessive guilt because our patient has poor prognosis. We're trying our best, but patient is not improving. That gets to you. We are overtly compliant, so we don't want to discuss that with anybody. We just hold on to that. And then we become a part of a compartment in which we're living and just thinking why this patient is not getting well and how much I'm contributing to that. And many times you're doing your best, but patient still has a bad prognosis. So I don't know if you have seen that, but these are the changes in the burnout by specialty. And there is the dark blue color is 2013, and the light blue is showing increase from 2013 to 2017. And you can see emergency medicine is on the top, OBGYN is at the second number, family medicine, and here is internal medicine. So you can see that burnout is on rise. You also will see that you can find rheumatology here too. Okay, so yes, we don't have that crazy work hours as rheumatologists, but we do have a lot of stressful patients, lot of patients which do not have black and white disease. They are in a gray zone, and they are not getting better. And we are feeling the emotional stress why a patient is not getting diagnosed. I also want you to pay attention that pediatricians are not that high in that thing. Trying to find where peds went. They were, probably looked from here, would be better. Yeah, so they had only 30%, and then they increased, that burnout increased there too. One of the plausible mechanisms for pediatricians not having that big of a burnout is because kids are kind of fun to be around, and that helps pediatricians. There is an emergency medicine, internal medicine, and OB/GYN and family medicine. They are at the forefront of that because these are frontline fields, and they see a lot of sick patients. They see a lot of trauma. Internal medicine doctors see a lot of complex and challenging patients. So what are the demographics for people who have burnout more than others? Young doctors, doctors who go out and finish training and they are in a solo practice. Women tend to have more burnout. So all the surveys they conducted in Stanford, they found out that male physicians had a 34% burnout, and women physicians have a 39% burnout. And we will look at the differences why. A greater number of work hours per week also contributes to that. Private practice, in which you have a target to achieve, and you have 7 minutes per patient to see sometime, that puts extra stress. Incentive-based salary structure, so you are in this worry of you have to make a certain mark, otherwise you will not be able to make it. So those are all the burnout risk factors. Some other contributing factors that we need to keep in mind, which exaggerate this problem much more, is if your workload is a constant spillover, you are never able to keep up with your work. Control. You don't have a control on your schedule, on the choices you make, on the decisions you make of how you want to practice medicine. It also contributes to more burnout. Reward. If you don't think you are being rewarded enough, you're not getting the same recognition or financial incentives, and you are working really hard, then it also leads to significant burnout. Community, what kind of environment you work with. You cannot be stronger than your allies. You have good networking, you have social contacts, and you have good friends to help you in the time of need. Fairness, the place you work has transparent policies, and everything seems fair to you. The things which are happening, they are good. Values, your values, whatever is your core mission in medicine, your organization and employer should have the same mission too. If your values mismatch, there is high chance that you will have burnout. So when I was looking at the burnout models, something which surprised me, that these been there forever. Some of these models are there from 1980s. And they basically, all these models try to show you, this one says that depersonalization is first thing, and then it leads to low personal accomplishment, and then it leads to emotional exhaustion. And these two models say, no, emotional exhaustion comes first, then comes depersonalization, and then lead to low personal accomplishment. So this MASLACH burnout inventory has been one of a popular tool from 1980s, early 1980s, in which there are different items in the survey that are asked to physicians. Emotional exhaustion examples are, I feel emotionally drained by my work. I feel fatigued when I get up in the morning and have to face another day at job. Depersonalization is, I worry that this job is hardening me emotionally. I feel I treat some patients as if they were impersonal objects. Personal achievement questions are, I have accomplished many useful things in my work. I deal very effectively with the problem of my patients. So using this inventory, you can, looking at the scores, see if the patient have significant degree of, if physician has emotional exhaustion and they feel very tired and they feel like they can never recuperate, or they are getting calloused toward patients, toward colleagues, and it's being noticed, or they also feel that what they're doing is not meaningful to them anymore. So this is one of the study which came in 2011. And this is one of the study which brought a whole lot of attention toward physician burnout. And it is a study done on Dutch general practitioners. And they noticed that 20% of them had burnout, and they used the inventory that I discussed earlier. And they also noticed that burnout happens in men and women differently. I apologize if you can't read it very well, but these are 18 studies they look through, and they realize that women burnout always start with emotional exhaustion, and males usually have more depersonalization at job. So in the female pattern, in this classic order of 3 things, stage 1 is burnout. Female doctors start with emotional exhaustion. They traditionally support others in numerous areas of their life, at home, at work. So they have so much energy that they have given around, and there's only so much to go around, and now they feel they are just totally empty. And that's how they feel with emotional exhaustion. Then it leads to a dysfunctional coping mechanism of depersonalization and cynicism. You start seeing patients as object, you start blaming them rather than looking at what's going on with your own self. And then they start doubting that are they providing quality of care to their patient, and if they are making any difference in patient's life or not. In the male pattern of physician burnout, men usually start with depersonalization and cynicism, and that's as a coping mechanism for them. And later they develop emotional exhaustion. But by comparison to female physician, they do not feel the low personal accomplishment part. So these are people who are working, they have burnout, and they think that they are good doctors, but their patients are feeling that they're distant from them. Their workers are feeling they're distant from them. So if you're a practicing physician or a resident or a student, and you notice these signs are there, these are early warning signs that you have to look for. In women, exhaustion and feeling of not being able to recharge your batteries, followed by early sign of blaming your patients or clients. And in men, cynicism and blaming your patients or client, and followed by feeling very tired and exhausted. And if you notice these signs are there, what do we need to do? Just take a deep breath, and we need to take a break. We need to start taking care of ourselves. We have to start taking care of our personal needs. And we have to create boundaries for balanced life. Work-life balance is very, very important. And if you do that, you yourself, your staff, your trainees, your patients, your family, everybody would be glad that you recognize it and you started correcting that. What would happen if we don't do that? I think consequences are pretty bad. If you don't recognize physician burnout earlier, then couple of things which definitely you do not want to see is there is decreased patient satisfaction. So when patients going to fill those satisfaction surveys for you, they're going to say that I didn't think doctor talked to me enough, doctor listened to me, or doctor was connected with me. And there are more risk of medical errors. I saw literature, which for the time's sake I didn't put all of that they did studies and they saw more depersonalization led to more medical errors. There is also risk of litigation. If patients don't like you, they're going to sue you. All these things are the patient consequences. What are the personal risks? I think personal risks are much higher than the risks that you see with the patient care. So physicians can have a condition called compassion fatigue. They are feeling so emotionally exhausted. They feel like they are being sucked into a vortex. And what they do is they start working more and more to try to get rid of this feeling. And it just leads them to a downward spiral. And I think that's the time to recognize it. And it leads to STS, secondary traumatic stress. So the way we describe PTSD in people who have a bad event and afterward they have PTSD, this is the consequence of having bad physician burnout, that we can have secondary traumatic stress syndrome. There are physicians who end up having substance abuse because of that, because excessive stress of the job is hard to cope with. And there is also risk of suicide. So when you start looking at data on physician suicide, it's depressing. It is so depressing because it says 300 to 400 physicians die by suicide in US per year. So that's equivalent to losing 2 medical classes per year. So we have to think about it, why this happened. We are also noticing that this risk is higher than in general population. It's higher in male physician 2 to 3 times the general population, and it's 4 times higher in the female physicians. And unfortunately, when they commit suicide, they have access to all kinds of drugs. They have a better knowledge of committing suicide, so they are very successful. Some of the reason why physician suicide is the biggest challenge with this burnout, that unrecognized and untreated depression is a common theme. 1/3 of physicians have no regular doctors. And by the way, physicians are known to be bad patients. There is low rate of seeking help for depression. There are professional attitudes. We feel like we are Superman. We are supernatural. We can't get sick. We can't go see a doctor. And there is also concern of confidentiality, losing our licenses, and we are very sick most of the time when we seek help. So what we need to do, if we see somebody around us that have symptoms and full-blown syndrome of burnout, and they start looking like they are going into the danger zone. If you have a colleague around you who looks increasingly irritable, who is reckless, who looks sad, who look withdrawn, it's time to act. We just can't leave them alone. What we need to do is we have to do some assertive plans. We're not going to go to them and say, would you have lunch with me one day? You're going to say, we're going next week to lunch at some place. And why are we doing that? Because we want to sit down with them and discuss with them what is going wrong. Studies show if you ask somebody who is planning to do suicide, are you planning to kill yourself? It doesn't plant idea in their mind. But if they are planning to do so, and somebody asks, there is a reasonable chance that we may be able to act and prevent that. So we have to ask that. We can start with why you're feeling bad, what's going on, have you ever thought about that? And if they start telling you that they are feeling that way, there is a suicide prevention lifeline, which is a good help. And if you're not sure, just find a senior colleague, find a psychiatrist, find a trusted source and go talk to them and see what can you do to help at that time. It's very, very important. One of the proposed solutions to physician burnout is to address physician wellness. Wellness can be defined as the complex and multifaceted nature of physician physical, mental, and emotional health and well-being. So now we are hearing a whole lot of news and things about physician wellness being promoted, resident wellness being promoted, because this is the right time. We have to start thinking about it. How can we do that? So I want to say that, first of all, none of these interventions that we can say one intervention will help everybody, because every individual is different, so some interventions will work better for one person than other. But what I want to show you is that none of these interventions are very costly. We can do that. It can start with self-assessment, and you do a self-assessment of what your workload is. Do you have a control on your schedule or not? Do you feel rewarded of what you do or not? You can use biofeedback techniques. You can do mindful meditation, and we do have classes of mindful meditation which happen in our institute. And now we have started things like yoga. But other things that have been implemented in other institutes like Stanford and Harvard and Mayo is that using surveys of well-being index. Reflective methods, they are the methods in which you engage the community more so that we can start recognizing that burnout exists and we're going to help each other out at the time of need. We can connect and discuss the past and present questions and discuss various perspectives in a group format. One example of that is the flag group we do with the students. And I love that experience when we sit together and discuss those cases. But I think it is not only at student level we need that. We need that at the level of residents, at the level of faculty. So a couple of examples of reflective method or interventions include things like clinical debriefing. So there can be peer groups or anonymous hotline where you can call after you have seen a bad code, after you have seen some adverse outcome, something that you're struggling with. And clinical debriefing is the best way of unloading yourself. Other things that can be tried and have been tried are Balint groups. And I'm going to describe Balint groups in a minute. Let's first start with the well-being index. How can physician well-being index or surveys help us? So this is the example of the physician well-being index or survey from Mayo Clinic. It has 9 questions. It asks you, during the past month, have you felt burnout from your work? During the past month, have you worried that your work is hardening you emotionally? During the past month, have you ever felt bothered by feeling down, depressed, or hopeless? During the past month, have you fallen asleep while sitting inactive in a public place? During the past month, have you felt that all things you had to do were piling up so high that you couldn't overcome them? During the past month, have you been bothered by emotional problems such as feeling anxious, depressed, or irritable? During the past month, has your physical health interfered with your ability to do your daily work at home or away from home or a job? And then the last 2 questions are to see how much is your personal accomplishment. The work I do is meaningful to me. My work schedule leaves me enough time for my personal and family life. So I took this survey, and I was happy. I think this survey is very smart because it tells you, are you average, below average, or above average, the National Well-Being Index. So nobody wants to be average or below average. So I took it on the month that I'm not on consult, so you can see my well-being was very good, way above the national average. But I have to repeat. I can do this survey every month. I have to repeat it when I'm on consult and see what happens to my well-being. Other things that it showed me is my meaning in work is high, like that. Likelihood of burnout was low, below national average. My work-life balance was good. My risk of medical error was low, below the national average. My fatigue level was low. And suicide ideation was low. Okay? So I like that. But again, this is in a non-stressful, non-consult month. I plan to repeat it when I'm in consult again. So how can 9 questions tell me what my well-being is? It's a validated screening tool. It evaluates fatigue, depression, burnout, anxiety, stress, and mental and physical quality of life in medical profession. And it was developed by a multi-step validation in greater than 13,000 individuals. And they did separate studies for students, for residents, for physicians. And over 20,000 physicians have used this index. And then when they compare it to the national average, not only this survey is good to see how much distress you feel, it also is a good way of looking at after adverse consequences like medical error, or if there is suicidal ideation, it picks things right. And then it also shows that do you have career satisfaction or not, and do you have any intent to leave the current job. So all these things are good about this survey, and it is something you can do monthly to keep a track of how you're feeling about your job. Now coming to other methods, including the reflective intervention, this is an example of a study they did in Mayo in 2014. And what they did is they took practicing 74 physicians, and they made a group of 8 and 9 physicians who met every other week for 1 hour for 19 weeks. During this 1 hour, these physicians talk about their difficult cases, their job experiences, and things like that. And the control group was 350 participants who were just allowed to have 1 hour of protected time from the job. At the end of the study, what they noticed is that intervention increased sense of meaning and empowerment in physicians, and it decreased their burnout. They also noticed that their depersonalization was decreased, and that gain sustained for almost 12 months. And on the other side, the control group physician also felt improved. not to that extent as that physician group met together, but they also felt improved. So that gives you an idea of that there are reflective interventions that can be used to help people who are feeling burnout or feeling depersonalized at job. Now we come to Balint groups. So Balint group are named after a psychoanalyst named Michael Balint. He was a psychoanalyst in UK. In late 1950s, his wife and they decided they're going to start doing psychological training seminar for GP in London. These Balint group they were based to improve patient-doctor relationship. This guy coined the term patient-centered medicine. And this is true for today too. At the center of medicine, there is always a human relationship between a patient and a doctor. And if you look at the consequences of burnout, this relationship is really getting bad, or it is in big danger if the doctors are depersonalized. A Balint group is a group of clinicians who meet regularly to present clinical cases in order to improve and to better understand the doctor-patient relationship. It focuses on enhancing the clinician ability to connect with and care for the patient's sustainability. So in this session, they have two group leaders, and they say that, do you have any case? One person describe a difficult case, and then some physician act like they are in physician's shoe and other act like they are in patient's shoe. And they try to bring different perspective about the doctor-patient relationship. So here the main focus is to improve doctor-patient relationship by attending those Balint groups. And they may meet for months or years, and they develop a group cohesion and they develop a trust over time. And this is another good mechanism of reflective interaction or interventions by which we can improve burnout in physicians. So I found there is an American Balint Society, and I was impressed to see there was a person here from Shreveport who is a certified Balint leader, something that we need to think or implement in our program too. So some of the important points about physician burnout that I could take by looking at all this data and evidence is that feeling depressed, exhausted, and irritable can be normal part of a physician life. We don't need to be guilty about it. There are days I feel like I used to be a better human being than this. And I was very worried about something, or I was frustrated about something. It may be a medicine that is not getting approved, and I have done 2-3 prior authorizations. So if these features are there, it will not improve us as physicians. We have to recognize it. And if we recognize it and we correct it, it will take only little effort and time. And we can't quit the jobs. We can't change the job because that's not going to be the required solution. I think that as age advances and people see this burnout problem, especially in old age, I think the easier way is to say, okay, I'm going to retire. Well, people who are very early in their career, they cannot think that way. And people who are so experienced, who have so much knowledge, they are irreplaceable in medicine field. So if we are not taking care of them and they are going away from medicine because of that, it's a big loss for our institute and the community. So I thought I'll just, after looking at all the evidence and everything, I will put my 2 cents of important points that I wanted to say to everybody. So to trainees, I want to say that you can't survive medicine without mentors. I have had mentors throughout my life. I had mentors when I was student, I had mentors when I was resident, fellow, and I still have mentors. I was interviewing somebody yesterday, and I said to her, how you cope with stress? She had to think for a while, and then she told me that she dances or listens to music. And then I said, you have to have mentors. And I have my mentors. And she looked at me and says, attendings have mentors too? Everybody needs mentors. They can be on-site mentors, they can be off-site mentors. That's your best way of not get into that big problem of burnout, because you can go talk to them and vent with them the questions and the things that are boggling, they are affecting you and your patient care. And then you have to have true friends. So 1 million followers on Twitter, and 1,000 likes on Facebook, they do not replace one true friend. So all of us have to have one true friend. Why I want to emphasize that? Because I did a study at Harvard in which this was a study in men looking for secret of happiness. And this is the longest study on adult life. And they did surveys, and the people who were involved in that, they were billionaires, president of United States, and people who were not so well off. And what they noticed is that the people who lived longer and happier, they had a good friendship and family support system. So 19 of those men are still alive in 90s. And what they found from the survey, that the solution to happiest and long life was having a community life and having friends. And these friends are there. They will ask you what's wrong with you. And the times when there is a need that somebody should come and ask you what is wrong with you. For the female colleagues, I want to say we have to set priorities. We always want to give. We want to give so much, and we are always compassionate about it. But we need sometimes a delegation log at job and at home too. Because sometimes we are overdoing and not knowing we are overdoing. And on a lighter note, nobody has ever died because their house was not sparkling clean. For male colleagues, I want to say they have to spend more time with their family. Because if they spend a little bit more time with their kids, with their family, it will help them to not having the withdrawal and social isolation. I had one colleague of mine who was doing a fellowship with me in rheumatology, and he said, I don't have to care about my kids' school plays and all those because my wife is so good and she takes care of all of that. Guess what? If you go and attend your school, kids' school play, and father also shows up there, your kids are so happy. And you will feel very happy afterwards too. So I told him, I said, she is very good, but you have to be there. The last thing I want to say is to my senior colleagues, that none of us care to have a primary care. So people of my age group is the time to start getting a primary care. Because that's the age when they call so-called midlife crisis start. Diabetes, hypertension, knee osteoarthritis. And I'm talking with experience. My knees hurt now. So you have to have a primary care. You have to start taking care of yourself. And for my senior colleagues, as long as I've been in this institute, I've seen my seniors work 10 times harder than me. And they never take off. And they all have a 1 year of vacation accumulated. And when you ask them when you would take off, they say another day. Because patients need me, students need me, mentors need me, I'm not going to take off. So if you have that much vacation accumulated, you need a vacation. Please plan for it. And spend time with your grandkids, because you saw Pediatrics had the less burnout, because they were around young kids. So young kids are fun. I would also say sometimes I feel like some of my seniors are working with me. They don't need vacation, they need staycation. So when there is a need, we have to do a staycation, because that's the only way we'll be better doctors, we'll be better, providing better care to our patients, because we need to recharge ourselves. There are days when I have at home spent a couple of hours without doing any job work and felt guilty of it. I could do this, I could do that, I could do some research, I could read Dexers, I could do so many other things. But then I realized, no, I have recharged myself and I deserve to do that. And if we don't do that, we're not going to be good doctors. So there are some good websites. I want you to look at them. They are nice websites. I thought they had some neat ideas there. Among them, one website is the WellMD website of Stanford. In that website, what I notice is, apart from the ideas of how to stay healthy, the best page I liked was the Get Help page, because I felt like this page is something that we need here too. In that page, this has a nice way for faculty, for residents, for fellows, for students. When you need mental help, what are the lines to call? We have to have that mechanism in place. So when we are feeling down and we don't know who to call, there are nice numbers to call here. In fact, this would be the best way of thinking as a head start. We need to have a wellness department. And that wellness department should have all these counselors and anonymous hotlines and the numbers where we can call when we are not feeling that this is our best day. We all gonna have bad days. That's the reality of medicine. That's the reality of practicing in medicine field. So we have to do these things. So I would like to summarize at the end that our understanding of physician burnout is continually expanding. It's imperative to detect burnout at early age or early phase to prevent the full-blown symptoms. It's important to focus on the good mental health of physicians and to take the gender differences into account while we are making programs. For men, focus on the coping capacities to avoid withdrawal and isolation. For women, we have to evaluate what are the determinants of fatigue and prevent the exhaustion by boundary setting. We may have to also do innovative work and leave arrangements for some people. Mayo Hospital medicine department have decided they're not going to do any meeting apart from the timing between 8 to 5. This is because they are trying to respect people's family time. And I think that is a good idea. So not have, and many times there are some places I have given grand round at 6:30 to another department, and their grand round routinely happen at 6:30. So we have to look into these things. So if we can change some of those things, they would be good for the mental health of our trainees and good to prevent physician burnout. I also had come across the time back idea from Stanford, which I thought was a neat idea. Of course, that requires money. This was a project they did in 2015 in which they got a grant for their emergency medicine doctor who do shift work, and there is a significant rate of burnout among them. So they provided them, there would be meal vouchers, other things, help with household work that they could spend more time with the family or at job feel more well and less burnout. So these are all things which have been implemented in different institutions and departments to promote physician wellness. So the take home would be that physician wellness consideration will start from third-year medical student onwards. And why I'm saying that, because once somebody, I was telling somebody I'm going to do grand round on burnout, and they said, are you going to cry for help? And I wanted to tell them, no, I'm not crying for help. I'm trying to tell you that this is a true problem which exists in healthcare system, a system which is not conducive to the well-being of human beings. When they did surveys on medical students before starting their clinical rotation, their level of stress and burnout was similar to US population. But from third year onward, it increased. And that just tells you that this is a system problem. And in that, more interventions we will implement, more chances that we will develop a very supportive, very engaged environment where we're always looking out for each other. Some of my references from different journals, American Foundation for Suicide Prevention, WellMD websites of Stanford and Mayo. Having said that, when I think of hope for the future of healthcare, I meet friends in community who ask me, would you want somebody to be a doctor? Should we encourage our kids to be a doctor? And I always think that yes, few years from now, couple of decades from now, people who practice medicine, they're going to have more focus on their well-being. They're going to be better physicians than us. My son wrote a poem on hope. He brought it to me while I was making the grand round, and I said, I can use it in my grand round, and he was so happy about it. So this is my 7th grader writing hope. Hope is like a flame. It keeps you warm inside. If it were to ever go out, there would always be a cry. It never stops burning, even when it's small. It's still enough to keep you up, even while it's storming. As long as it's there, you will get through the rough. If a wild storm would come to put out the flame, if you were to let it, your life would never be the same. So my hope is that we can have a better idea of taking care of ourselves and not be a victim of physician burnout. I'm happy to answer any questions now.